Testosterone and sex drive matter, no question. But if that is all you are watching, you might miss what is quietly stealing your energy, longevity, and life itself. Dr. Josie Tenore helps us connect the dots and focus on what really protects and empowers men's health. Welcome to WellWaveNOW, your portal for actionable wellness insights. We, Breck Rice, Dr. Bob Levine, and Tim Daniels, are your wellness analysts committed to elevating your health, enhancing your functionality, and optimizing your performance at every life stage. WellWaveNOW, where timeless wisdom lights your wellness path. We welcome back as our guest today, Dr. Josie Tenore. Earlier, I gave the Italian pronunciation, so I'm going to now go to the American pronunciation, Josie Tenore. Founder and medical director of Trevi Health, a progressive wellness and longevity clinic rooted in science, personalization, and performance-driven outcomes. With decades of clinical practice, Dr. Tenore has helped men move from fatigue, confusion, and stalled health goals to clear action plans that protect vitality and extend health span. In today's conversation, she helps us examine what men care about, what they might be missing, and this is for anyone who wants to optimize their performance, prevent what's preventable, and build lasting health the smart way.
Hi, Dr. Josie. It's so great to have you back on the show.
Great to be back, but he didn't have to stress the decades. You really have to stress the decades.
We have to, because that fits your image. If you're talking about longevity, and you got to make sure you've got longevity yourself.
Well, you started when you were 10 anyway, so
yeah.
And like we were talking about before everybody came in, you're probably about the same age as Bob, but you look much better than Bob. So it pays up for you on both ends, longevity and.
Wait till I finish my cleanse before you say that.
Yeah. Well, hey, let's get back to the men's health part of this. But you know what? What's interesting is that a lot of men. I think there's a mismatch, right, of what men worry about and what they actually should be worried about. And so I wanted to jump into that.
Yeah. So as you've in your practice and as you've worked with us men, what are the top health concerns men typically voice, and how do those compare to what you think are the actual leading causes of death and chronic challenges for us?
So, I'm going to keep this clean. So the number one concern that men have is sexual performance. That's the biggest concern, where they actually can voice it, not only to me as a provider, but to their peers. That's something they can joke around about. And it's linked with testosterone. And then I think second is probably cancer, because, everyone has a friend who has prostate cancer. And again, prostate cancer links to performance, the fear of you losing it if you have that diagnosis. And so those are sort of the top things that men are concerned about. And, the number one killer of men is heart disease. It's not prostate cancer, although that's what men fear. So there is that disconnect there. Number two killer for men is cancer. But number one is heart disease. And, so there should be a little bit more of a concern, but, at least if the concern about sexual performance gets them in the door, at least then we can get them towards getting healthier.
So libido and cancer kind of headline always, it seems like, but we should be more focused on the heart disease and the stroke is what you're saying.
Yeah.
Those are the silent ones, the ones that people don't really feel too much, right?
Well, they're not really silent, so they're sometimes the symptoms are misconstrued, so fatigue. Oh, I've had a lot of stress. Well, fatigue can be not enough blood flowing through your arteries and getting to your muscles in your brain. And so it's not just, hey, I'm under a lot of stress, or, my erections are not as strong as they used to be. That's like, okay, maybe my prostate's acting up. Maybe it's stress, when in fact it could be arteries that are not feeding the muscles in that organ. And so those are often symptoms of underlying either diabetes or heart disease that are often not associated correctly with what might be going on.
So those are some of the blind spots or indications or misreads that men have. Are those the most prevalent blind spots, or are there other blind spots that are missing?
Well, I think that sometimes, we all do this as humans because we want to appear to be, a functioning, lively, youthful person. But sometimes I had a friend, this interesting story, who I looked at him and all I could see was visceral fat, inflammation, potential for diabetes, risk for cancer. And, he had some interesting story about how his doctor told him he had unusual muscles. and that he had these like unusual, genetically predetermined muscles. And this was
Were those table muscles? What?
this was his story until he ended up in the hospital in diabetic ketoacidosis. So
Wow.
I'll explain what that is in English. It's basically when your blood sugar is, sky high in the 800 and 900s, which drives all the blood out of your bloodstream. And you're actually in a state of what we call vascular collapse. So unless we get fluids in those veins, in those arteries, you die. So, his little, I have unusual genetically weird muscles really was not that at all. It
Good
was,
smoke screen. Good smoke screen.
but
Now,
that
do
was,
you-
so it's this delusion that we have. We all have these stories in our head about our health, and that was sort of happened to be his. And to me, I mean, I don't say things to friends unless they ask, but it was like, I just see bad things in your future. And, unfortunately, he ended up diabetic and having cancer as well. So
Hmm.
I was not wrong. So yeah, so those are the big.
But we might as well get on to one of the the top topics and talk about testosterone and its myth, the myths about it, the measurement, and the missteps around it a little bit. So what is testosterone? What role does it really play? And why do you think it's not always understood?
So, I mean, testosterone is one of the, hormones that the body manufactures, both men and women. Men manufacture more of it. And it's, it's pretty crucial to, most other organs, the brain, the muscle, the emotional aspect of the brain, not just the functioning aspect, the heart tissue. I mean, there's receptors everywhere. And so, but testosterone has also become a societal term. It's not just like a hormone, because I think this feeds into sort of some of the issues that men have, because they re-equate testosterone to virility and to strength and to being a good provider and to being a strong member of the community and to being, an effective entrepreneur. And there's so many other roles that have nothing to do with physiology that has become associated with this cute little hormone that's got all these little connections on it. So it's an interesting, that is something that's actually consistent with all cultures. So, if you want to have some cultural equality, in all cultures, testosterone's virility, whether you're African American, whether you're Caribbean American, Hispanic, European, been in the US forever and you can call yourself actually American, it is prevalent in all cultures. And it'd be nice if it would be something that would join us all together. But it is one of those things that is not unique to one culture.
Okay. So across all those cultures, if probably all are worried about losing that and then having this thing that's out there, low T. I keep seeing it on every advertisement. They've got retired football player, retired baseball player running around saying, "Hey, I fixed my low T." So how big a problem in two ways? How big a problem in terms of prevalence is low T, and how big a problem is that really to a person's health? And you're so sharp, I'm giving you like a quadruple part question here. And then how do you identify?
Computer's going.
How do you really identify if somebody's got low T?
So, if you want the medical definition, the medical definition is a laboratory test. It's a blood test. So if you have less than 300 nanograms per deciliter, if you want to be so specific, and you have symptoms. Now in the Urological Society, it's not good enough that you just have a low number. You have to have symptoms. And so symptoms can be fatigue, decreased libido, loss of muscle, increased fat, mood changes. This is sort of what you need to have. The issue is that I will see those symptoms when the testosterone isn't necessarily less than 300. I will see it if it's in the 400 and 500 range. So, and we don't have normal ranges anymore. We used to talk about the normal range. Well, now we have reference ranges. So what does that mean? The population has aged, and so the numbers have gone down. So now your reference range, if you look at it at scale, our reference ranges are lower. So, when I talk to men, it's like, okay, so your testosterone is like a 95-year-old and you have symptoms. Do you want to be a 17-year-old or do you want to be a 95-year-old? So we sort of look at the reference ranges. I pay attention to that, but essentially, I treat humans and not numbers. But that is the definition. And it is shockingly more prevalent now with the obesity crisis that's happened forget about North America. It's actually globally. It's a global phenomenon now. So we're seeing a lot more of low T in at least low T symptoms in all men, but definitely in younger men.
Yeah, I was going to bring that up because we've talked a lot about, that could be fairly natural occurrence in older men as you age, but younger and younger men are now showing low testosterone levels. What do you think is driving that trend?
How many hours do we have? I think we have what? So, if you want to like condense it, inactivity, too much screen time, not enough physical activity, diet, obesity is huge. And then we can't ignore everything in the environment that we've now labeled as hormone disruptors, whether it's hormones in dairy products or it's plastics that we get from microwaving food in our, in plastic containers. I think I saw a report that I'm in Chicago. Lake Michigan has the levels of microplastics in Lake Michigan is shocking. And we get our drinking water from Lake Michigan. So, I'm hoping my water filter filters out the plastics, but I don't know, like how small are these particles? So I think there's a lot of factors that really drive all our hormones, and this applies to women too, but we're seeing it a lot in younger men. And it's kind of frightening because the infertility is in younger men is also increasing as a result.
Wow.
Well, no, so I know we're focused on men's health here today,
Yeah.
but a brief divergence. So, and curiosity just popped into my mind, so I have to ask it. And Bob and I are like that in that regard. We're similar in that regard. Uh, does the testosterone production of women trail off, and is low T a problem in women?
Hell yeah.
Hmm.
The big issue with women is that there's no large scale trials that have been done on testosterone in women. So we don't have a lot of data. And when I talk to my patients, it's like, sorry, testosterone is not FDA approved for women, but, shame on us in healthcare and in research to have abandoned women's health since the Women's Health Initiative. But, women will present with a lot of symptoms. The standard one that most women will readily come in for is I got this tire around my middle. So they'll come in perimenopausally with, some increased fat around their middle that they're not used to. But then when you probe and ask, a lot of them postmenopausal have no libido, like zero, no, none. It's like, I'd rather eat cookies than, than do that. And so, at least the Menopause Society has recognized that testosterone is helpful for hyposexual disorder. But, I would say menopause equals hyposexual disorder in women because a lot of them will lose it. So it's very important.
Right. Appreciate that. Then now I'm going to link you back to something else. You mentioned you seem to be obsessed with fat today. Did you put on 10 pounds, Dr. Josie, or something? You talked about the women come in, they got in this, and then 3 times the length of fat to testosterone. I'm starting to look down at my gut and say, hey, I better get a little off here. But but what is that? Maybe others.
My obsession?
No. There may be others thinking the same thing or ask the same question. You mentioned obesity and testosterone a couple times, well, 3 times when you talk about the women and 2 times with men. Is there a direct relationship? Is the fat producing something that drives those testosterone? Or are you linking it back up to the inactive? Because the activity, certain types of exercise can up that. So you're saying is it the lack of exercise that does that? So what's really going on there with fat and testosterone?
Excellent question, Tim. I liked that one. So when I talk about fat, I'm not talking, patients come in, they're like, I want to lose weight. I'm like, I could care less about your weight. That's not what I'm interested in. I'm interested in visceral fat. So visceral fat is the fat that wraps itself around your heart, your lungs, your liver, and it acts like its own organ. So when you have a visceral fat, I always tell my patients, I want to get your visceral fat under 10. When it's higher, it acts like its own organ and it manufactures its own chemicals. So I'm not going to get overly complicated and give you medical terms, but you just have to take my word for it. It will create inflammatory chemicals. So then you start to get, inflammation. It can stimulate certain hormones as well, which then, everything in hormones is like a circle. If you have too much of this, it turns this down. So Bob's got a hand up, but let me just finish my thought. So it acts like an organ, and we need to turn this organ off to enable it to have less inflammation and less other stimulation. So Bob, you had a question.
Just in this regard, how do you measure visceral fat, the fat that's all around the organs? How does that, you said if you want it to be under 10, what is that measurement?
I'm referring to, we'll get it. Yeah, I'm referring to a device I have in the office that measures body composition. So they've got these scales now. You can buy them on Amazon, an in-body scale, and it will give you, your muscle, your fat, your water, and all the rest of that. And the more sophisticated medical grade will also give you a readout on visceral fat, and it'll show you where your fat deposits are.
Wow, that's amazing.
Yeah, so we'll get into sort of like, I think at the end we'll probably talk about what men should do, but that's where I get my numbers from. So I follow that when I take patients on a journey towards better health.
Okay, I have another follow-up question. Tim, let me just jump in here for a second. So when visceral fat is like 20 or whatever it is, how do you advise, what is your advice for people to get their visceral fat reduced and under control?
I mean, it depends on what shows up in the workup. I mean, usually I'll do a full workup, I'll throw in a body comp, and then, I always find out what the patient's goals are. I mean, sometimes they're not really interested in health. They're interested in, I want to lose weight, or I want to have lower cholesterol or whatever. So, all of the standard advice that we should be giving, and not every physician is skilled at the dietary portion of it, but obviously looking at diet, looking at sleep, looking at community, looking at exercise. Like, I have a lot of people who don't have time to exercise. So I'm like, get a weighted vest. Let's just get you a weighted vest. I have somebody who runs in his factory. So he is walking, but he's not putting enough, because it's a constant similar stress. So I'm like, okay, add a weighted vest and just add it 15 minutes of your day when you're walking in your factory, just like 15. Don't give me any more than that. But let's start with bite-sized baby step goals. And, we usually start with that. And then it depends. If somebody has, 150 pounds to lose, we add in, medications, and we add in peptides of different forms because, they work and they're helpful.
Okay.
Yeah.
So thanks for answering that. Now, before I pose the next question to you, go back, if you would, and recap the impact of low T on a person's life.
Okay, so it can have, blinking back to the visceral fat, if you have low T, you don't move as much because you're tired. Your workout efficiency isn't as good, so you don't build as much lean muscle. The more lean muscle you have, the higher your metabolism is. The higher your metabolism, it's so it kind of all, the more you exercise, the more you can naturally increase your testosterone in both men and women. It's not just in men. So, having no energy, not being able to think clearly, if it does then give you higher visceral fat, then that puts you at risk for all diseases, heart disease, diabetes, cancer. It's sort of like the number one. I don't look at cholesterol as being the number one issue. It's really visceral fat, because that has a lot more to do with health. So, it can really affect the quality of men's life, because they're not motivated to get off the couch. And it's like, no kidding. Like it's hard to get moving if you don't have enough fuel. So it can be very life altering to have take.
So you've got a big quality of life issue, as well as, mental acuity and performance on that. And then you've got the exposure from, for the health aspect to other conditions that could terminate you.
And,
So
and I do have to bring this in because it's huge in the news and I sometimes forget about it, but mental health.
Mhm.
And so, if you look at the suicide rate amongst males, it's high, and I'm not saying that, hey, it's all low T. That's simplistic, but if you're have performance issues and you have no energy and you can't function at work and you're not making as much money, I mean, it all links to this sense of failure. And, we can't ignore the fact that mental health is on the rise and suicide's on the rise.
okay.
Yeah.
So with all that, so you identify that somebody's got low T and they're having some symptoms. What do you think people should consider for the therapy and the therapy for that? When do you advocate something? So what types of intervention do you advocate or work on for that low T? And how do you determine the appropriate amount of any type of action for them?
Yeah, I mean, assuming that I've had the full panel done, I've got all the data in front of me. Then I also have to identify, if what are the patient's goals and how quickly do they want to get to where we need to go. So if the journey is long and scary,
Hmm?
we have to start with little tiny baby steps. If somebody's like, I got a wedding in, X number of months, I got to look good, I got to function, then that's a completely different story. But also the age, if somebody's young and they qualify with a clinical diagnosis, a urological stamp diagnosis of testosterone under 300 and symptoms, I don't necessarily put them on testosterone replacement therapy. I do everything that I can to sort of wake up those testicles to make their own. So dietary intervention, physical, certain medications that stimulate production naturally. So we start with working with the body's own tools and then only adding in, sort of extraneous tools if we need to, if we're not getting anywhere.
Yeah. We've talked a lot about, the levels of energy and performance and everything that is on the physical side of testosterone. What about with the relation or the correlation to diseases like prostate cancer? Where's that correlation?
So that's again, how many hours do I have? So testosterone, it's so interesting to me that we have created an entire plan of care for men with a diagnosis of prostate cancer based on one study that wasn't randomized, done on, it was like 3 men in the 40s. It was like 2 or 3 men who had metastatic disease. And they observed that if you took away the testosterone, the tumor shrunk. So suddenly we have this belief that it's like kerosene, and like you take testosterone, you throw it on the prostate cancer, you're gonna have a forest fire. And the reality is it doesn't quite work that way. Testosterone, like the cancer will have a certain number of receptors on it. So like think of keyholes, so there's so many, the door will only have so many keyholes. And once you've got a key in every keyhole, having more testosterone isn't going to make it grow because there's no receptor for the testosterone to bind to. So we've now sort of started to realize that there's a relationship to, they call it the saturation model. And so men can actually, even men with prostate cancer, depending on the individual, can even be treated with testosterone for their prostate cancer. And we've started to really understand that the risk of prostate cancer isn't from high testosterone. It's actually low testosterone. You're more at risk to developing prostate cancer if your testosterone level is chronically low than the other way around. So, but that's what we do. What do we do with men? The second they get a diagnosis is we put them on blockers. So it suddenly, yes, and their tumor does shrink, but it doesn't mean that it's a treatment or a cure.
Wow. You want me to do our promo for this week, Tim?
Sure, go right ahead.
All right. Have you tried this yet? It's called NeuroGum. And I saw it on the #1 podcast in the world. Thought, hey, it's good enough for that show. It's good enough for our show as well here on the WellWaveNOW show. But it's full of nootropics for energy and focus, natural caffeine, vitamin B12, B6, and the amino acid L-theanine. also known for improving cognitive function. It's sugar-free, tastes great, so refresh your body and your mind with NeuroGum. There's a special going on right now in the TikTok shop. We'll leave a link in the show notes for you. So now back to the show. Dr. Josie, we've talked a lot about, the hormones, testosterone, and how that tells that part of the story, but there's more to it, right? We've got it a little bit into metabolism and also inflammation. So let's kind of address, you were hot on the topic of obesity. That has a lot to do with metabolism, right? So let's get into that a little more, because I'm seeing I mentioned earlier seeing low T in younger adults, but we've got a real problem with young men and obesity in this country right now. And I think a lot of that is just everything is motorized now. No one rides a bicycle. It's all electronic, doing all the pedaling for them or scootering them everywhere. How is that affecting young men's hormonal balances?
I mean, we talked a little bit about physical activity stimulating muscle growth. The more muscle you have, the more testosterone you make. So it's a vicious cycle. The more testosterone you have, the more muscle you make. The more muscle you make. So, inactivity is, and it has to be very thoughtful. And if you can get it has to start with children, because unless it becomes a habit early on, it's not something that's very easy for people to add to their life as they're adults, because it's not, I've been moving since I was born, probably before I was born, and it's like so ingrained in me that my natural reaction when I feel stressed is to work out. But, young people have, babies, their screens are their babysitters often. Although I think parents are becoming very savvy to that now, and they're limiting screen time. But if you're not moving as much, and we have availability of food that tastes really good but has no nutritional value in it, you put the two together and you are going to get, your again, some of this nutritionally deficient food will create some inflammation, which then creates more of the hormones that cause more inflammation, which slows down metabolism, and it just starts up this vicious cycle that's very difficult to break.
Great. So back in the old days of IBM, and IBM was known as being a top place for people who present, and I learned people like Bob were in that era, and they bring it back up and tell people every now and then about it. It used to say, tell them what you're going to tell them, and tell them what you told them. So you told us about visceral fat before and inflammation, a little bit about inflammation. You told us a lot about inflammation, but I also want you to reiterate the problems with visceral fat, because that's a big issue, and then also talk about the problems caused by inflammation, because there's in some camps, some people believe that inflammation is the root of all disease. So tell us about that before I ask you another question. If you will.
And if it's not the root, it's at least the check engine light, right, on the engine.
Yeah. I think it's, I find in healthcare, we kind of sometimes get very narrow focused in our thinking and belief where, inflammation is the root of everything. Well, it's part of the story. It's a significant part of the story, but if you got rid of inflammation and you still had visceral fat, you're still having other hormones that are created that are still disruptive. So, but inflammation, the problem with it is that it can be very low level, harmful without having any symptoms whatsoever. So you can, until it's a little bit too late. So you can get, the inside of your arteries, there's these little fingers in it called the glycocalyx. Well, if that's destroyed, then the inside of the artery becomes very sticky. So things start to stick to it. But so if your little teeny tiny arteries are not fueling all of your end organs, your skin doesn't look as good, your kidneys don't work as well. So it really does affect every single organ, probably indirectly, just because it affects blood flow. And there's a lot of different chemicals that can then directly impact brain and heart, and so it is very significant, but it's in isolation. I don't like to talk about anything in isolation, but it is significant.
And with so much focus on, an overweight population and the rise in diabetes and, the topic of visceral fat that we've been talking about, what is your opinion on these GLP-1s? We see them everywhere, right? And you mentioned peptides earlier. That's something that you use. What's your opinion on the GLP-1s?
GLP-1s are peptides,
Right.
just
Yeah.
just to be clear. So I mean, unless you're blessed enough to live somewhere where you have no access to any kind of TV or TikTok or whatever, everybody knows what a GLP-1 is.
Yeah.
So, Ozempic seems to be cropped up a lot. And so, I mean, they have hit the world by storm because they work, they do, but they don't, you still have to do the work. They do provide tools, but the human body is it's really designed for survival. So yes, buying your GLP-1s on the internet, it's all well and good. However, if you don't have somebody supervising how these medications are affecting your body, you can create a worse problem. I had one of my patients who, my cardiologist is going to give me my medicine. Okay. So I see her for hormone pellets, and she came in, I see women every 3 months. So she comes in 3 months later, and yeah, she lost weight, but 100% of it was muscle.
Yeah.
And her visceral fat didn't change, and her fat percentage didn't change. And it's like, great, you've now just made yourself sicker. So
Mhm.
yes, these medications will, what they do is they keep the stomach full longer, which then tells the stomach to send messages to the brain, hey, you're full, you whatever, stop eating. And so that's the Ozempic Wegovy type of drug. And then the other one, they call it a twin cretin because it has a direct effect on the brain and on the gut. So it tells the brain, stop thinking about food. It cuts off like a lot of food noise. People who really struggle with a lot of weight have these conversations in their head that those of us who don't have them. So it directly impacts the neurotransmitters in the brain. So it makes food, it creates a food aversion. So it's sort of like, you know what, that smell of fries is making me nauseous. I don't think I'll eat them. As opposed to, that McDonald's, I can't wait to go in. So they do work, but if you're not exercising and fueling your body with nutrients, you may end up losing muscle, 100% muscle, and not getting any healthier. So
Yeah.
and then eventually what happens is, if you run out of money and you can't buy it anymore, or somehow you can't get it on the internet, then what'll happen is you now have less muscle. So your metabolism is even lower than it was. And so that rebound, you're going to gain whatever you lost and then double it because you have less muscle and less metabolism than you started off with. So
Yeah.
but they are phenomenal. They are phenomenal drugs. They are a game changer. I will not say that they are not. They've helped a lot of people, but I still think that just doing it, without somebody looking after your nutrition and your muscle mass and your visceral fat, you may not achieve the overall goal of better health down the road.
And can you, if you do all those additional things with complementary things or the full picture, they're going to call it, can you get off those drugs, or do you have to stay on them forever in order to maintain that weight loss?
So it depends on the individual. Like I now approach, some of my patients, if you struggle with weight, I'm going to tell you, people who struggle feel like they're constant failures. Because as a society, we look at those people and we equate fat to, lazy to, non-productive. Like we have all these words, and, people, and they do. And a lot of these individuals, their bodies are designed to like survive. So I tell them there's nothing wrong with your body. It's supremely efficient. And we're going to take an efficient machine, make it inefficient. And if you think at the end of the day, we stop this medication and it's going to be inefficient. No. So there are people who and again, if we have the apocalypse, they're going to live, and like all the skinny bitches are all going to die because they don't have any in reserve. Right. So it depends on the individual. If somebody's struggling with 20 to 40 premenopausal, or male andropause, and it's affecting all of the things that they used to do. They used to do mindfulness. They used to work out. They used to eat healthier. if you have somebody who's genetically programmed to be, maybe hang on to a little bit of extra fat, which is totally perfectly healthy, they can be off these drugs after you correct whatever got them there in the first place. But if you're dealing with those that are genetically programmed for survival, then those individuals, I reassure them there's nothing wrong with their bodies, but we do have to remove some of the illness creating problems that have occurred because their bodies are so efficient, and that they will have the expectation that they will be on these medications lifelong because we are body hacking.
I just realized, there was one thing, I went to this, and I had a biopsy done, and one doctor says something to me, I'm glad you came in because of XYZ, but didn't have results. So I went back to the doctor I was looking to, and I said, he said this and that. What does that really mean? He was giving, it sounded to me, is that some special doctor code they're talking? You were just talking some special doctor code, Dr. Josie, that you have to translate. What was that? Your body's programs are for survival. What do you mean? People just that people just like those people who just naturally have a lot of weight on them and have a metabolism that just lets them accumulate fat in general. Is that the translation?
So the translation, because I thought that was less technical and less scientific, but so there
It was
are
less technical and less scientific, but it was still
Dr.
Dr. Tom.
So there are people who genetically make more insulin and they don't make enough adiponectin. And so they're, in a way, they're sort of pre-diabetic. So their genetics quickly gets them to that stage. And if you have insulin's a fat storing hormone. So if your insulin is high, it's just going to store fat. And if your adiponectin, it's a fat burning hormone. If your adiponectin's low, you're not going to burn it. So people who have this just, high levels of insulin and low adiponectin, that is a survival mechanism that the human body created to deal with the times of famine when we were back in the Stone Age, where we would like find an animal, kill it, find some green things because it's warm enough, add it to our meat because it makes it more flavorful. We get other nutrients, and then you have 3 months where there's no food, and so you hibernate for 3 months, and then spring comes. So those hormone adaptations were created to be able to deal with those periods where there was no food. The problem is we haven't had a famine in over 100 years. I mean, even COVID didn't create a famine. So there are individuals genetically that are programmed to have those hormones kick in really quickly, and they're very much programmed for survival.
What percentage of people fit in that category, though? Because when you're talking genetics, a lot of people think genetics are unchangeable, which we know is not totally true. But when you look at how people lived, 50 years ago, for instance, there weren't so many morbidly obese people running around. Are all of our morbidly obese people and obese people suffering from this genetic genetic predisposition? Or I just don't think that the percentage is that high.
It's not necessarily, but if you look at, anytime, well, I actually wrote a paper way back when I went to New Zealand, and I noticed that the indigenous community had the same health issues that they did when I trained in Canada, that the native Canadians had. And I sort of wrote a paper on the introduction of Europeans, who brought in sugar and alcohol, and all of a sudden their health went down the tube. So I do think that it is part of mammals, it is part of the mammalian phenomenon, but so it's not genetic in the sense that this culture has it more. It's just if this culture is changed into a different one or introduced, a new culture comes in, then some of those adaptive phenotypes are expressed. So, I don't have at the top of my head like how many, because there is an obesity epidemic. So I would have to say it's probably higher than we even know. But it is something that can be changed. You can change that. You can body hack and make your body less built for survival. So yes, I can't ever become 5'7", and my eyes will always be brown, but I can change how well my body can burn fuel.
So to get to that point of changing, like you talked about earlier, that if you wait too late, the little fingers in the arteries are gone, and then you can get the stiffness in there. If you wait too late, the visceral fat starts destroying things. So if you look at it though, even and we talked about the low T and all those things. Sometimes though, even high performing males, whether it's from business or athletes or whatever, they'll delay looking for care. So let's talk about that, and let's talk about why. And this will please Dr. Bob with his full Ayurvedic leaning and everything. So
Let's
what
not
have
forget
you
about traditional Chinese medicine either, okay?
that too, traditional China. Yeah, and I've been more, I'm like you. I heard the Ayurvedic because that's kind of popping in my mind a little bit. But I've always been more from my the folks I used to study martial arts from mainland China, more on the traditional Oriental and Chinese medicine side on that. But that aside, so what do you see as some of the common physiological, psychological, cultural reasons why you see men wait too long to get checked out?
Remember, we started the conversation with testosterone has a cultural connotation, right? So it's, in our society, men they really feel this pressure to be, macho. And you can't admit that something is not functioning well because it takes away from the virility. And so there is, there's that drives it. But, but I don't think that men are, as a culture, we haven't programmed men to seek care preventatively. So, women we teach them. For example, initially moms will bring their kids in for well child checks, and depending on, I won't get into politics, but immunization checks. So, and every kid has to have a well school check before they're going to school. So they're dragged into the doctor annually. But then what happens is there's this, except for that annual, if you leave the school thing, girls then, oh, we don't want Annie to become pregnant, so let's get her on the pill, or let's take her to the gynae. And then girls go once a year for preventative care. They get pap smears, they get their whatever taken care of. So they're now programmed that it's okay to go annually. And then they get pregnant. What happens? They go monthly. So they start going monthly, and it's for pregnancy care. So there's
That's a
this,
great point. These are great points.
yeah, so there's this education that we have that women sort of associates going to the doctor for prevention and wellness care. Whereas men, it's like, well, if it works, don't fix it. Like, why do I need to go to the doctor? Everything's fine. I don't have any symptoms. Everything's fine. Or if there are some symptoms, there's this underlying fear that maybe something is going to be desperately wrong. And then what? How am I going to provide for my family? How am I going to go to work? How am I going to, like, if I'm in a hospital, what happens? Well, unfortunately, sometimes what happens is they drop dead. So they die before they even hit the ground because all of those little subtle clues are ignored. And so you take the two. We don't educate men that prevention is appropriate. And then we have this cultural expectation that men have to be this all-knowing God. And so you get a lot of delays. And then there's this fear, like, can I even admit that I might actually have some medical condition? I mean, nobody wants to be sick. Like, that's not a good feeling. You want to be healthy and strong and vibrant.
So, Dr. Josie, you've made some incredibly important points that seem to be focused more on our society here, maybe more Western medicine. Is that the same? Is it hardwired in men's DNA in other places that you've been, or is this a Western culture that we're not as, I guess, in tune to not wanting to be weak, or is that a hardwired thing in New Zealand and other places that you've been?
I mean, New Zealand, it depends on if you're talking about the Maoris versus the Western Europeans that ended up there. So, in other cultures, they may address things differently in a more spiritual way. So you may have spiritual circles, and they may, depending on the culture, smoke the peyote pipe together. So other cultures may address some of this, but I do think that there still is, even in those cultures, there still is this persona that the male has to be very strong. And so they may consume things to improve virility and strength, and they're open to that. But when it comes to admitting that, maybe they should get screened for high blood pressure or diabetes, that's not the same as, hey, let's take this and you're going to be, a stronger member of the community.
Mm-hmm.
Yeah, I always think of the difference between genetic inheritance and behavioral inheritance. So behavioral inheritance is what is going on, I think, with men because they behaviorally they inherit the idea that they have to be strong, they have to be tough, they have to provide, and so I think it's like cultural conversations, behavioral inheritance that drive men to not want to admit. And the women are telling the men in general, hey, go get this checked out, go get that checked out. What do you think about this? Or do you think you're on the right path health wise? And the men are going, I'm fine.
But think of like the playground, right? Little kids playing in the playground. A little girl falls and skins her knee. A little boy falls and skins her knee. What's the little girl told? Oh, you poor thing, are you okay? And you get all of this compassion. The boys told, buck up, be a man. Come on, just like keep going. It doesn't, unless your limb is falling off, you can do it. So
Rub
even
some dirt in it.
just, yeah, rub dirt in it. It's fine. Spit in it, like get the scab.
Strengthen your immune system.
Yeah, whatever. Yeah, strengthen your immune system. So, I mean, this cultural education starts at a very young age, and we don't sometimes even know we do.
All right, so Dr. Bob and Josie, without turning Breck and I into wimps, what do you advocate to be able to get men to be more proactive?
So, I told you at the beginning, I'm a KISS person, keep it simple, stupid.
Mhm.
So I tell men, get a tape measure,
Mhm.
put it around your waist. If that number is bigger than the measurement around your hips,
Mhm.
run, don't walk to the doctor. That's very easy. If it's the abdominal measurement is a very good, quick indicator of how much visceral fat there is. If you have a skinny waist and big butt and big heavy thighs, you might be really, really healthy, but that is not true. So the apple
Mhm.
is associated with more ill health. So if you don't want to look at your fatigue or you don't want to dismiss that to stress, that's probably the easiest way for a male to be able to go in and confidently say, you know what, my waist is bigger than my hips. I think I need your help.
Great point. That's a great tip. That's a universal, simple tip. I love it.
It's got to be simple.
Good.
Yeah, it does.
Now, we talked, we've talked about young and old men, and you've talked about the thing in New Zealand and the Maori. Are there underserved populations, I think, amongst men? And if so, what are the disparities? And another part three for you for my Harvard educated, almost as good as a Stanford educated person.
Which would be Tim, everybody, just in case you didn't
One of
catch
my
that.
one of my best friends is a Stanford grad, and we get along just fine. So
So are are there underserved communities? What are those disparities? And again, what do you think those communities should maybe take to them if there are to do themselves, and how can we help those communities of men?
I mean, God, I wish I could say that in America, health is a human right. Health and education are not human rights here, I'm afraid. So there is disparity because of just poverty, wealth. That's probably the biggest divider. So you see the most disparity based on money. If you can get insurance, then you have more access. If you don't have insurance, even after Obamacare, I mean, there's a collective, there's an exchange. Well, you know what? A lot of doctors don't take that insurance. So if you don't have a way to get your care funded, you're not going to go and get your care funded. And then, if you look at wealthier communities where you have people of color, one of my professors at Harvard, her thesis was internalized racism. And what she found was that those individuals who publicly declared, man, there's racism in my neighborhood. Like, when I pull into my driveway, I get treated differently than my neighbor. Those who can verbalize it actually are healthier. But it makes sense. Like if you sort of are a denier, like, oh, I'm not discriminated against, then it feeds in and it kind of is it's a psychological stimulus. So, there's wealth, there's also racism, there's education. I mean, I think, as I alluded to before, we've conditioned girls to get educated to get health. We need to do a better job of having that message for males too. Like you should go in for your annual exam. Yes, Bob?
Well, I'm going to play a little bit of devil's advocate here because, I've been through a lot of wealthy communities. There are a lot of unhealthy people there. They got tons of money. they got multiple houses, multiple cars, they take vacations all the time, you know, and their health is awful.
Yes.
That's a big percentage of people who have the money. And so what's going on? I mean, is it really about the money or is it about, I mean, because they, you know, anyway, that's what I wanted to say.
It's not 100% about the money. That's a good point. Thank you for calling me on that. But I'm looking at sort of what, some of the time I spent doing public health clinics, and there's when it's that, when you have such a huge discrimination, that yes, there are access, and they typically, if you don't have insurance, you present late, but that doesn't mean that denial is not just the longest river in Africa. It's big in
All
wealthy
communities, everybody.
and I think that if you look at the wealthier the communities, they sort of feel like I can buy health, not so
Yeah,
much.
until they can't, right? Until
Well,
they
they can't.
realize they can't. Yeah.
Right. So, I do think there's that little bit of denial of like, I can afford to get this care, or I'll get my concierge doc. So now I have a concierge doc. Well, if you never use the concierge doc, it's not going to be helpful. So
Right.
there's education that has to go towards like getting appropriate care. And we need to do a better job for males. And if we can't, then, as companies, the company owners should have, I think we're starting to see this, wellness clinics, wellness offerings, wellness incentives. If you get screened for diabetes, if you improve your diabetic score, you get a bonus. Like I'm starting to see that in companies. So I do think that we're recognizing that it's really expensive to have all of these unhealthy people, and that we do need to figure out a way to get prevention back in, and at least bring in some of the prevention tools that we know, even if you have ill health, it's going to improve your quality of life and it will improve your health outcomes.
Yeah. So as we wrap up here, Dr. Josie, we've talked about, you gave the great advice of taking the measuring tape around your hips and your belly. And that's Dr. Bob's got his tape measure. He's ready to do it.
Simple,
Yeah.
yeah. I'm
Very
afraid
practical.
I'm afraid of the result, but I'm going to do it anyway. Go ahead.
That's practical and immediate. But what are some of the lab values that men should be aware of and that we should be tracking on a regular basis?
So I think if, obviously I like a full comprehensive, but if you want to like boil it down, if somebody just gets a testosterone level, that's not good enough. We need to know what the free testosterone is, what is available for work, because some of it can be attached to another, it can be attached to protein and not be available. And if, one other test that I think is really important is something called a Hormone IR. So it's basically an assessment of how the body handles insulin. So if that's off, then that gives us a pretty good indication of what we need to get done. So I would like cholesterol, the rest of that. I mean, there's a long, long panel, but I think if you wanted to focus on a couple of things that should be done in men, those are the ones that I really focus on. And of PSA, of course, because you want to make sure that prostate's okay.
Yeah, I'll add that even that prostate, on the prostate one. I had PSA, I guess, 2 years ago, and it came back great. And then my doctor, and I go to a female doctor. I like to go to female doctors for a number of reasons.
We have smaller fingers.
You should clarify
Well,
that.
you were going then. Well, since you went there, I will say part of it is that I will say amongst African American males, they have more of a higher prevalence towards prostate cancer. Anyway. I did tell myself when I was probably in my 30s, I did not want any man sticking their finger into me for a rectal exam. So that's one of the reasons I do go to women, is because that's okay. If they want to stick their finger, if they're all right. But that was basically the point. So she had taken the PSA and it was great. And she told me, bend over. And I said, you're going to do that too? He said, yes. We said, I won't if you don't want me to, but I think we should. Boom. So I just think, for that portion, since we've talked about the prostate, I will advocate, and that you should also get that physical exam in addition to the PSA one.
But Breck asked me about lab.
Yes, I know, but I'm just adding. This is just my public service now. But Breck had his public service announcement, so I get to have my public service now.
It's true.
So if somebody comes into you and they've taken the step, but they're confused and they're still not getting the traction you want with them, how do you begin to motivate those men, or what do you encourage those men to do to really kind of get themselves on the right track?
I mean, I spend a lot of time there. Bob will like it. I ask a lot of questions. I spend a lot of time listening, and I try to figure out, by listening, I try to see what are the hurdles that are set too high. What can't they overcome? It's like the example I gave of the factory worker. You know, he's like, I'm exhausted. I run around the factory all day long. I'm exhausted. I don't want to work out. Like maybe I'll get Sunday in. So then I'll find actionable small tips to try to get them doing something a little bit different so that we can have a different outcome. Like, you know, the data on exercise, for example, you know, we've known now for a while that high intensity interval training really does stress the heart better than, you know, low intensity long, right? So, but what the new data suggests, it doesn't have to be contiguous.
Right.
So
Yeah, get it right. When you said high intensity interval training, that's the key.
yes.
It's like a sprint and a walk, and then a sprint and then a walk. I just wanted to
Right.
clarify.
But the new data suggests it doesn't have to be sprint, walk for a 45-minute period of time consecutively. So now I tell people, you know what, you got a minute? Go up and down, like figure out what your heart, like whatever brings your heart into training, so it changes as you get older. Do a minute and then get back to your computer. And then, you know, oh, an hour later, I got a minute now. Do another minute. So you can break it up. And so we've discovered that as long as you do a certain amount of it, you are still training your heart. It doesn't have, so it's like, oh, I don't have to join Orange Theory. Fabulous. I don't, you know, so because a lot of times just that kind of commitment is just too large a bite. So, you know, I'll give little baby bites because I think it's
Snacks.
snacks,
We
exercise snacks.
Movement snacks.
Movement snacks. We at
Yes.
we might actually trademark this one day, but we at WellWaveNOW call those movement snacks, and we have a whole podcast on that can help people. Where can people and how can people reach you if they want your now movement snacks, or they want your broader advice? And then after you give us that kind of wrap for us and tell us what do you think? What do you think you've taught these three hard-headed men today to take away?
Okay, so you know, the easiest way to get a hold of me is my website, trevihealth.co. So what I hoped to have accomplished today was to sort of like help to, you know, bring to the focus this discrepancy between what's really affecting men's health and sort of what men are concerned about. And I'm hoping to stimulate conversation and amongst males so that they can be comfortable talking about some of these issues amongst themselves. I mean, women are always blabbing about, oh, I'm fatigued and I think I'm perimenopausal. And what did you do? And men just don't have those sorts of conversations. So have those conversations and, you know, keep listening to this podcast because you'll get good information. So I'll do a plug for you guys. But I'm
Yeah,
hoping
appreciate that.
that I've made it sort of, I've simplified some of these complex concepts and that you know, it motivates men to take care of themselves.
Well, thank you for that. And for all men listening, what you miss can really hurt you. So this episode has provided great insights for men's health. And it's more than just hormones and libido, right? It's about alignment, action, and smarter, you know, priorities and movement snacks. I'll add that too as well. So, Dr. Josie, thank you for helping us reframe, you know, the conversation here and give men the clarity that if you take the right steps at the right time, you'll have a longer, stronger life. And until next time, everyone stay curious, stay empowered, and remember, wellness, it's in you.